It's a pleasure to be here. The last time we did this, we had technical difficulties and didn't get started until late. And so I insisted that we get together earlier to make sure we didn't have any technical difficulties, but Kathy is out of power, and which is perfect preparation for disaster psychiatry talk. Always think about what to do if you run out of power, how to get more. And I think last night with the snowfall, a number of us were thinking about that. So I have done part of this before. I'm going to try to be focusing this on DC, and I'd like you all to be thinking about what your role would be in a disaster, where you would go, what you would do. For some of you, you're in a hospital, some of you are private practice, and I'm hoping that this can be a nucleus of more discussion. Slide, please. We struggled to find a recent disaster in Washington, D.C. We went back to the events almost 40 years ago when the plane crashed into the bridge and into the river. And I thought we would be focusing more on the wildfires since they've been so awful for such a long time. However, slide please. We did have a disaster a couple weeks ago, and you see the boat trying to find the plane there. One of the considerations to think about is how much visuals to use. We know it's not good to watch videos of planes flying into towers over and over. So I've kind of minimized the videos of this. I want you all to think about also what you would do in this type of disaster as opposed to some of the others I'm talking about, because there's different roles. Slide, please. So, top 10 lessons learned is that we want to plan before a disaster. We want to do a needs assessment before we intervene. And your needs and your interventions are going to change over time. And then there's a lot of other lessons learned, which we'll cover in more detail. Slide, please. Little bit of background. About 25 years ago, we were doing a lot of quote critical incident stress debriefings or psychological debriefings. And I'll tell you who we is in a moment, became concerned that these might be doing more harm than good. There's a school shooting. People get together who have been near the shooter. They tell their trauma again. So you not only have your trauma, but you have the trauma of the kid next to you who went under the desk. And was that helpful or not? We got together a conference at Airlie House, which is a wonderful location for a conference if you can get some money for it. And we put out a book called Mass Violence and Early Intervention. There's been several books since there. The new chapter in Disaster Psychiatry is just out, and an excellent read, Disaster Psychiatry Readiness Evaluation and Treatment with Fred Stoddard, Craig Katz, Dr. Brenner. I'd recommend that's just out now. Slide, please. So the first thing you want to think about is the type of event, because people respond very differently if they know the event is coming, if it's suddenly a tornado hits. We know that there's all kinds of disasters, and I believe, and I think probably most of the people on the call do, is that climate change is increasing them. Is it a man-made disaster or an accident? And often the level of anger will change depending on if it's perceived that, say, the government does something wrong or Pepco is doing something wrong. Is it a terrorist event? We're not really going to talk about complex humanitarian emergencies today. Maybe Dr. Dyer will do that talk another time. We're not going to talk very much about war and occupation. We're going to touch on what are variously called weapons of mass destruction, weapons of mass disruption, or sea burning events, and think about the analogy to COVID. Slide. Preparation. So this I took from our actual preparation prior to the inaugural. Doesn't that seem like a long time ago? We were worried about violence. This comes from Craig Diatley, and he's in charge of disasters in management in general for Washington Hospital Center, which is the lead for the city. And so he was outlining here what was happening, the People's March, the MAGA rally, the Caps game, and the other things. And this is something that the disaster planners are going to be doing for every major event. Unfortunately, we don't often work with the planners, and that's one of the things that I think we should be doing more as much as possible. As it turned out, the inauguration went relatively smoothly, but preparation is key. Slide, please. And then before you do an intervention, you want to do an assessment. Why do you want to do an assessment? To develop a plan. You're going to be asked by command and families and media. You're going to want to say, where should my resources go? And what are targeted intervention? The history of disaster psychiatry is replete with poorly guided interventions, which don't make the mark and maybe make people feel worse than they did before. So, and this isn't a one time thing. Remember, there's a time phase for this to be looking at what's needed. Slide, please. And you want to do it on an individual basis. We're used to doing that, group and a population. And there's question about vulnerable populations. Some people consider the chronically mentally ill more vulnerable. I consider them in some ways more resilient. They've spent days, weeks sleeping on the streets. The physically ill, the disabled, we saw this in Hurricane Katrina, where the disabled couldn't get out of the nursing facilities they were in, the elderly, and children. And again, I think it's an open question whether children are more vulnerable or less. It kind of depends on the family structure, the parents especially. Slide. And first, you're going to look at physical needs. What are the numbers of those affected? Is it 67 like we had on the plane and the helicopter, or is it thousands and thousands? What shelter do people have? What food, wounds, illnesses, infectious diseases, medications? Often fuel is critical, or electricity, like we're finding out tonight. And is this violent event a one-time off one, or is it part of a series? Are there mass fatalities? Slide. And then after the physical needs, think about the mental health needs. We've already talked about some vulnerable populations. In this part of the world, we have a number of people from all over the world, many of which may have been tortured or bereaved in other parts of the world. What is their medications? Where are the medications? Often in a big disaster, the supply of psychiatric medication isn't there. We saw that in Katrina with New Orleans. And then when people that's severely mentally ill get off their medication, they tend to become more disruptive. What are your number of hospital beds, your routine psychiatric beds? Is this going to cause more psychiatric admissions, whatever this is? We're always short on psychiatric beds in the city, and is it going to cause the shortage to increase? Dead bodies, we saw after the tsunami the pictures of hundreds and hundreds of dead bodies. And these usually aren't an infectious disease risk, but they are a psychological toxin, especially if they start to rot, bloat, smell. Slide. Okay, if you're going down somewhere, and the example here, Katrina, we sent teams from SAMHSA down, try to get as much information before you go, because often the power will be out where you go. You won't be able to get on your nice little laptop and look it up there. You usually want to do an on-the-ground assessment as well, but avoid just driving around and the windshield survey. Who should you talk to? Community leaders, shelters, clergy. Psychometric assessments are usually not very helpful. I think we're cut the bottom of that slide off, at least on mine, but people don't like having a clipboard stuck in their face asking them how they're feeling.
In that central area between clothing and furniture. We don't have pictures of that layout, but
I'm hearing somebody talking. Slide, please. And then what are your resources? The traditional resources we're familiar with, the Crisis Counseling Center, again, medication, psychiatric, and medical. What languages are spoken in the region, and who do you have who can speak those languages? Slide, please. There is often a honeymoon right after the disaster. The media come in, the politicians come in, And then they leave, and there often is still the long cleanup. We see that with the floods down in North Carolina. And feelings of bitterness, abandonment, and anger at the government often emerge. And if you are some way representing the government, for example, working with FEMA, providing counseling, trying to do the right thing, being good to the world, you think, you may be the target of that anger. And if you're preparing people to go deploy, then you really need to make sure that they're aware that that may happen. Slide, please. And things can be pretty dangerous. In the shelters we had in Katrina, we had mental health, medical personnel robbed, and other violence done to them. I'm just going to touch on infectious agents here. We have thought about them a lot through the years. In the military, there was inoculation against anthrax for people who deploy, but not for people who stayed here. And of course, you all remember, or those who are old enough to remember the envelopes with anthrax in them. Slide. The issues around chemical and biological agents is often you don't know if you've been exposed. You don't know the numbers potentially exposed. You don't know the infectious nature. We used to think that the emergency rooms would be overwhelmed by people presenting for care, but then we wondered about people not presenting for care. This slide was developed a long time ago, before when I was in the military, and we were very concerned about chemical and biological agents. Slide. One of the challenges that we've seen is that COVID has the same not knowing if you've been exposed and the infectivities. Slide, please. The sea burning, again, chemical, biological, radiological, the names keep changing. It's often invisible. The symptoms can be multifaceted: uncertainty, unfamiliarity, grotesqueness. Slide, please. This next slide is a little gross. This is from smallpox. And so there's a whole level of fear that you might be exposed to an agent like smallpox. Slide, please. And COVID is similarly invisible, ubiquitous symptoms, uncertainty, no longer novel. Now, COVID's this whole other talk. Slide, please. And many of you are ready to get that one. Wanted to emphasize a little bit about immediate disaster behaviors, and that can be how do you escape out of a metro if it is in a crash or out of the way of a tsunami wave. And I am a big believer in rehearsals, muscle memories, drills, and recommend that you do drill wherever you drill. That's a leftover from the military mission. Navy's very big on drills, getting into the lifeboats. For first responders, what we often see is, do they go and take care of their family first, or do they go to the disaster? Critically important for all of us to have our disaster preparation, but certainly for first responders who are expected to run towards the flames, that you want to have a good family care plan. So if there's a shortage, as often there will be a shortage, the who gets the lifeboats, again, I developed the slide before COVID, but the question about medications, vaccines, masks are all very relevant. Then you can have the sensory overload of mass destruction. Slide, please. Acute psychiatric issues, stress as reaction to terrorism, additional fear of the unknown. Have I been exposed? Changes in mental status secondary to the agent. Maybe it's a nerve agent, the Russian nerve agent, and we don't know whether this is a change because of mental health condition or nerve agent. Medical triage. Do we try to triage somebody into the hospital, out? We have seen, again, all of these under COVID, the quarantine, and of course, today was a snow day. Some of us worked. Then loss and grief, underreaction, psychological denial, fatalism, gonna die anyway, why bother to store any food? Slide. and then the longer term fallout of agents. Slide, please. Then the longer term includes depression, PTSD, somatic, that's body symptoms, overreactions, anger at the government, as I mentioned, multiple unexplained physical symptoms. We could look at long COVID as an example of that. And then the effects on the economy, collapse of tourism, flight of business. We see this downtown. When we go downtown, all the stores for lease. And then traditionally, unemployment hits often the people at the bottom of the income chain. So they are now maybe out of food, out of work, and that traditionally is linked to both domestic violence and episodes of self-harm. Okay, slide. This slide I like. This is drawn from the Fort Hood attack, which I'm not going to talk in detail about today, but Major Nadal Hassan looking at the most immediately affected, the survivors of the deceased injured persons who was present during the attack, and then going out to first responders, local providers, military community, affected unit, then the larger nation. And we can look at this with almost any disaster. The plane going into the river, we have the family members of the deceased, we have the community of ice skaters, we have the helicopter community, and there's probably many others as we go out. I was talking to one of the St. Elizabeth's residents today, who I think is on the call, and she was talking about just seeing the plane in the river and being so close to it. So there's a lot of different populations at risk, and your interventions, again, are going to be somewhat different for the different populations. Slide, please. So I'm going to go back again for a moment to the early days when we were wrestling with what we could do instead of critical incident stress debriefing. Slide. And we came up with some basics that have now been pretty much codified into, mainly it's called psychological first aid. It took a long time for the aircraft carrier to turn around to stop doing critical incident stress debriefings, but I think we've gotten most of the way there. Slide, please. And I'm going to go through these in what we thought was most important to people at the time. Bottom line is people don't want to go see a psychiatrist right after seeing their friend shot or a major accident. They are going to be concerned about basic needs, safety, security, survival, food and shelter, and communication, knowing that your family is alive. Slide, please. And then the psychological first aid, as I said, this is pretty much embedded in most disaster responses at this time, and facilitate reunion, provide information, protect from further harm. If you can, reduce physiological arousal. For you residents out there, I hope you're getting this in your training program. If not, go bug your training directors and tell them that you need a little bit more information on this. You can look up some of it just on the internet, but it's one thing to look it up and another to follow and practice it. And by the way, a lot of this is not going to be done by psychiatrists. It's going to be done by mental health counselors, social workers. I'll come a little later to more what can be done by psychiatrists. But the psychiatrist should be in the planning, again, planning and preparation. Slide, please. This often gets forgotten about, but go back to 9/11 in New York. People went up on the pile. They didn't care about the asbestos. They wanted to save anybody they could save. And nobody really was monitoring the recovery environment. And that needs to be done because later on it's going to come back and bite you if you don't. Because people are going to be concerned once the adrenaline has worn off and there's no more people to save. Well, what did this do to my lungs? And then it's not a one-time threat. You have to be monitoring for other threats and for people who come in who say, oh, I just want to help, but you don't know what their skill set is and you don't know what their intentions are. So you want to have somebody who's minding the perimeter, the recovery environment. Slide, please. Outreach is so important. People really want to know what's going on. After 9/11 at the Pentagon, we did a lot of therapy by walking around. People like the personal touch. Use established community structures, that's often churches and schools. And we get used to saying, oh, just go on the website. I'm going to do it a little later on. But if you're in an area with no power, flyers can be very helpful. The Center for Traumatic Stress Studies at the Uniformed Services University has a lot of information up on their website that you can just modify, print it out, and take 100 or 200 with you when you're going. Slide, please. This is something where psychiatrists should participate. We want to do technical assistance, we want to do consultation, but you shouldn't wait until the disaster, because when you go up to Mayor Bowser and say, hey, I'm Dr. Dyer and I know everything about this, and Major Mayor Bauer doesn't know you from Adam, that's not the right time to do it. You want to be doing links beforehand. And I think this is one thing that I'd like us tonight, to think about together, how we can link better. The Disaster Psychiatry Committee of WPS isn't a committee at the moment. It's me. I'd like to encourage it to be a committee. I see Julia Frank, you had this job some time ago, you're on the line, and I don't know if it was a committee back then, but I'd like us all be a more robust network, because we're a city that's prone to disasters and riots, other things. Slide. Fostering resilience. Resiliency is such an overused word. It means so many different things to different people. But here's a few bullets. How can you do social interactions? After 9/11, I recommended the workplace go out to TGIF. People in the Pentagon had been working such long hours for so many days. Okay, take some time, have that potluck. Foster natural support. Looking after the bereaved, we often do it right away, but not so much 6 months later. And then there are some conditions that you will want to do operational debriefings in. And that's usually first responders who know each other, who've worked with each other before. It's usually should be done on a cognitive basis, rather than tell me about your deepest fears and feelings, but more about what went right, what went wrong, how can we learn better. One of the best ways to do debriefings, according to the Brits, I don't recommend this. It's called deep lager therapy. Everybody know what raising a pint is in the UK. So people go out and have social interactions with each other. Slide, please. Okay, so we know how to do triage. Again, you're going to have chronically mentally ill patients in a Katrina type setting who are off of medication. You will need emergency hospitalization in some cases. Hopefully we'll have enough beds. If not, we'll turn the auditorium into a room. Slide. And then finally, treatment. And I've mentioned this a couple times before, but I do want to reinforce that we may well run out of medications, and especially in prolonged conflict. I have no idea what's happened in Gaza. I haven't heard psychiatric medications mentioned, but I would assume that some people are off of them, and that's made the disruption even more intense. Slide. Interventions for chemical and biological warfare include all of the above, but one of the really strong things is a successful medical response bolsters a sense of safety. You remember when we had anthrax in the letters going up and down the East Coast, and we were all pretty scared. Gloves, tongs to get the letters out of the mailbox. But then we found that it could be treated with antibiotics, and the anxiety went way down. And then good risk communication. I actually think we tried to do a pretty good job in COVID. It didn't go so well ultimately, but and risk communications gets political a lot. That's not rare for the politics to intervene there. Slide. So I'd like to switch gears a little bit. This is from the chapter I mentioned in the Mass General Hospital's recent book, and this is kind of the key points, and this is focusing on psychiatry And by the way, I did the first disaster psychiatry fellowship in the United States at the Uniformed Services University, which was a combination of an MPH and a year. If there's anybody in the military on the call, that's great if you can get the fellowship. If there's anybody not in the military who's interested, maybe we can start something at St. Elizabeth's. That'd be a perfect place for a disaster psychiatry fellowship. And you can quote me to Dr. Swarty, who is in Italy and not on the line. So disaster psychiatry is an evolving field. A psychiatrist can have multiple roles, advocating for preparation and policy, as I've been doing, treatment of long-term effects, and the functions of the disaster psychiatrist shift according to the phase. It involves interfacing with multiple systems, psych, education, normal and pathological responses to disaster. We should be prepared to educate communities and assist with triage and provide treatment for individuals with pathological symptoms, either related to the disaster or pre-existing. Slide. A couple of other key points. There can be several treatment modalities. It's not all EMDR. It's psychological first aid, psychopharmacology, provision of individual and group psychotherapy, done in a sensitive manner. Slide. Special populations, we've talked about a little already, and we can help facilitate normal recovery process and promote wellness and resiliency. Slide. Now, I asked you at the beginning, what would your role be when disaster strikes? And I'm going to leave some time for us to talk through this, and then I've got a few backup slides. So it's going to differ depending on where you are. So at my hospital, MedStar Washington Hospital Center, we've got a very clear sense of what you do if a code orange sounds. And a code orange sounded at the time of the crash, but then it ended when there was realized you weren't survivors. However, 9/11, the burn victims went to hospital center. Clinic, again, are you affiliated with somebody? Can you help say, okay, I won't be in the first wave of volunteers. That'll be the people in the hospital, but I will sign up for week 2. Private practice, I think it's a little harder to define what your role would be if you're not affiliated. One of the issues that we wrestled with 9/11 was a question of licensure. You could only practice in Virginia if you had a Virginia license. Most of us did not. We talked for a while, including Dan Dodgen, who was the American Psychological Association then, and is now at APRI, which is a disaster part of HHS, worked for a while to say, hey, in a disaster, can we honor the other states' licenses? I don't think that ever happened, to the best of my knowledge. And then if you're in the military, you'll usually deploy with a military unit. The VA is one of the largest potential responders for disaster in healthcare, and they've certainly done a lot of it. After Katrina, a lot of veterans came up to the soldiers' home, treated by the VA there. HHS will have its role, SAMHSA, and other. So be thinking about what your role is. I was talking to, again, Miriam, one of the residents over at St. Elizabeth's today about this, and I don't know currently what the DBH plan is for disasters, but I'm sure they have a plan. And is that something that the St. Elizabeth's residents fall under? That's the kind of thing that you can find out. Slide. Messaging and media are very, very important, as I mentioned a couple times before. And so after the plane crash, I spent a couple of days borrowing mainly from other people for messaging. And these are this comes from the American Psychiatric Association, and there's a lot of crosswalking between the APA and the Centers for Traumatic Stress. So the bottom line is you don't have to reinvent things. So basic messages, keep informed, but avoid overexposure. Don't watch planes fly into the towers over and over. Learn what local resources are available and share this information. If you feel angry, depressed, you're not alone. Talk. leave that telephone down. Talk to your family, talk to your friends, talk to the other psychiatrists that you work with. Slide. If you have contact with children, keep open dialogues with them. In time, the tragedy will pass. Don't minimize, but talk about your own ability to cope with tragedy. For advice to patients, anxiety and depression following a traumatic event are normal. If these symptoms continue even after order has been restored, seek the advice of a psychiatric physician. You know, people are, psychiatrists, us, are often asked, when should you go seek help? And there's kind of an implication that you should go see a therapist right away. And I recommend really using the support system you've got. And if a therapist is great, but a lot of people can't afford a therapist, they can't find a therapist, and saying go seek a therapist may leave them feeling a little bit more overwhelmed. So talk to other people. Slide. And then a couple of websites here that DC aircraft mid-air collision, and then one that's been around for a while, but then the increased emphasis of what happens if I'm scared to fly. What do I do with that? And I think that's a hard one. I'm not in a hurry to go take a flight out of Reagan anytime soon. Slide, please. So in summary, I'm going to incorporate the lessons learned, good risk communication, environmental monitoring, ongoing health assessment. I didn't talk about family assistance centers here. I did at the last one. We talked about the one that got set up at the Pentagon. I looked up family assistance centers as a result of this tragedy, and it appears that now the airlines are doing them. We did the one at the Sheraton with the for the military and the family members on the plane, but all the links I could find said various American Airlines staff were doing it. I also couldn't find where the family assistance center was, and I suspect they've tried to protect the privacy of the family members, which is appropriate. And self-care. Okay, slide. I'm going to acknowledge some of the many people who have worked on this. The top slide is me and Bruce Crow and Chuck Milliken outside the Pentagon. The bottom slide is me and Dave Benedict and Abu Ghraib, and I don't have pictures of everybody. I'm going to pause and take some questions here, slide, and then I've got a couple backup slides that I'll go to if we have time available, focusing on what we do at MedStar Hospital Center to set up a command post, and then what the curriculum is, the free curriculum at the Uniformed Services University. I will ask if people could identify themselves and keep the question pithy, and I'll try to keep my reactions pithy. Who's going to monitor for hands?
I can, Cam.
Okay.
I see Dr. Weissman has a question. He has his hand up.
Okay, why don't we start with him then?
Dr. Weissman?
Yeah, I wanted to share an experience I had and hear your thoughts about it. When 9/11 occurred, I dialed 911 with another friend who's also a psychiatrist and asked if we could be of any help. And the FBI invited us to come down to the Pentagon and station ourselves in, I assume, what you could call recovery or hospitality tents, where people who were doing recovery work came to refresh themselves as a way of monitoring anybody who was having difficulty. And what was so striking in that experience was the degree of resiliency and camaraderie the first responders had. There was no one who really, they were willing to talk about it, but no one, at least in the immediate situation, which you, as you point out, is not necessarily what happens later, was in any degree of distress. They were really quite pumped up in some way. The only group that was really different than that was when they located us in a tent for young recruits, young military people who were sifting through remains for body parts. And when they came into the tents to refresh themselves, they had a lot to talk about, but nobody fell apart. I I'm not talking predictively of what would happen after that, but it also raised another interesting observation. This is what I'd like your thoughts about. It has been claimed that during the London Blitz, people with neurotic anxiety disorders and other types of disorders uh, had a diminishment of their psychiatric symptoms in response to the adversity that they had to cope with externally. So that's another thought I'd like to hear what you have to say about.
Yeah, I think you raised a number of good points. The old guard, which is who was stationed at Fort Myers, were the ones that were tasked with a lot of that initial rescue work and then sifting through the remains. And they, I think, did have a sense of mission and morale. And one of the psychologists who was assigned to help them went in with them on a mission into the Pentagon, and he came out really shaken and was probably he shouldn't have gone in, though who knows. The the sense of mission is really important. After 9/11, we went to fight in Afghanistan, so there was a major sense of we are going to take the battle back to them. This is our mission to do. And again, that's part of the importance of knowing what your population is. You were probably pretty much wasted down there as going as a psychiatrist to intervene with first responders. Or maybe you had a little bit, but that's not your best use of your mission. Having said that, I'm surprised that if you called 911 911 that the FBI got to you, because they get very overwhelmed with the calls asking what people can do to help.
ID tag that they gave me from that. But I'd like to hear your thoughts about the London Blitz and people's responses to that in terms of neurotic disorders.
I'm going to throw that question open because I don't know the answer to it. It sounds reasonable that if you're threatened by bombs, your own neuroses become less important. Alan, I see you are on the line. You or anybody else want to respond to that? I like discussions more than lectures anyway.
Well, I don't know if I have anything too specific. One of the things that occurs to me as Steve is talking about it is that with an immediate threat, the kinds of secondary gain that one might hope for in terms of resolving relationships or some other kind of thing, there wouldn't be the opportunity for that. And then there's the kind of responding to the fight or flight situation, which is much more biological and psychological and much more immediate than historical. I like the points that you made, Cam, about the importance of a needs assessment, and also the idea that many of the psychological symptoms won't be immediately manifest, but will be later on. And of course, another perspective on this is whether you're going to some place like New Orleans after Katrina or Haiti after the earthquake, that a ophthalmologist can go in, get off the airplane, do cataracts for a week, get on the airplane, and the job is done. An orthopedic surgeon after the earthquake can do a lot of amputations. The job isn't necessarily done after that, but maybe get on the airplane and then other resources there for prostheses and for community support. But I think community support is an important aspect of what's going on or needs to go on, because it isn't just a case of lining up hundreds of individuals one after another and getting them involved in some kind of counseling session, but building a cadre within the community that will be there on an ongoing basis. And I think that's an important aspect.
I see Chris Flynn has his hand up.
Yeah, hey, Dr. Ritchie, thank you for a fascinating talk and really appreciate all of your experience in this. I was kind of responding to Dr. Weissman's question about the Blitz. I don't know the specific answer either, but I responded to a couple of major events while I was with State Department. One was the Cyclone Gonu that kind of wiped out Muscat, Oman, and another was a 100-year flood in Chennai. the reason I'm bringing that up is that when I got to those locations, I was talking with the Americans who were suffering from those events. At least the event didn't make their other problems go away. I mean, they were adding that problem to the ones that they already had. It sort of became listed in the priority list, right? I mean, well, my relationship with my husband and my children have not been going well, but we really do need to have clean water to drink. So that kind of goes to the top of the priority list. But anyway, in my view, I would be suspect to think that a new stressor would simply eradicate old stressors. I think it just reprioritizes, but adds a whole new level of burden. I'm out.
Okay, if there's no other hands, I'll go through the couple
Cam?
backups.
Cam,
Oh.
sorry to interrupt. I see Dr. Fagan has a hand up.
Yeah, hi.
Okay.
I'm Ron Fagan from the Alaska District Branch.
Okay.
I joined a DMAT, Disaster Medical Assistance Team, after 9/11 and attended some of your talks, Dr. Ritchie, back in those days. And I guess I don't know exactly what's going on in that system, but I always thought that there should have been some integration between what the district branch had to offer to the disaster medical teams that might show up in an area in some more organized way than just no organization at all. And I'm just curious if anything ever happened with that, any attempt made to get people hooked up into that system if a disaster occurred in that area and the teams showed up.
That's a really good question. And I haven't heard much about DMAP, Disaster Medical Assistant Teams, in years. I haven't been to one of their meetings in years. So
Nor have I.
I don't know how active, but that's certainly an area that should be developed more, and we should be working hand in hand. And are there any more hands? If not, I'm going to go through the other slides I've got, and then I know we have General Zanakis on the line, who's also a retired Army psychiatrist.
So my name is Shaukat Khan. I'm the Disaster Psychiatry Chairperson for Connecticut Psychiatric Society.
Okay.
And I just want to comment on the previous persons who commented on it about the collaboration. When the shooting disaster happened in Newtown, Connecticut, I was the Connecticut Psychiatrist Disasters Chairperson at that time too, and CPDD's representative in the Connecticut. So I responded in the aftermath of Newtown shooting, but I was helped by the Red Cross at that time. Being a member of the Red Cross really helped me to get the people there. So the point I'm trying to make is good to have the collaboration with other organizations, especially American Red Cross, which is very helpful. And another thing that I wanted to make a comment on the requirement of training. As you know that in the aftermath of 9/11 response, the responders suffer from significant mental illnesses, PTSD, depression, and other illnesses. So, and we always feel that we are ready to serve and we have a good intention, but for going to a place for serving, I think we should need to train ourselves beforehand and go with a group.
Agreed.
Sam, I think that speaks to your comment that we psychiatrists as an organization ought to be better integrated into whatever location we are. For instance, so most of us probably on this call are in the DC, the DMV. And you talked about Washington Hospital Center, having a presence in the district and with the government, but I wonder about local, like our WPS, being more integrated as well.
And given the climate change, effect of climate change, we disaster psychiatrists should include climate change in our agenda too. Climate effect of climate change. So that's also very important. I'm sorry, I stop.
Okay, let's just run through the rest of them quickly and then go back to the very good discussion. Could I have the next slide, please? Next slide. Okay, here we go. So this is our very concrete what we do if there's a code orange, and it's going to be different for everybody, but it helps us to have cards with what are the next steps, who to call, who do you link up with, Family Assistance Center, Emergency Department, Behavioral Health Response Team. That's what the BERT are, Casualty Care Leader. We have a vest that the team lead does. Slide. And this is just an example of what we do as what will happen. And we want to get that thought out in advance so we're not figuring out where to go at the time. Slide, please. And so we make sure that everybody signs in. We know where people are. We have it. We think it's going to be people on inpatient psychiatry or consult liaison who will respond first. Outpatient psychiatry should probably see all the patients they can and get ready if it's going to be a long-term response. Slide, please. Now, the other thing I wanted to show is that there is a disaster health core curriculum that the Uniformed Services has developed. It's free, it's 8 hours long, and there's a lot more in here. It can be taken all together or it's flexible. And I think that is something worth doing. Maybe if we get ourselves together to do more of a curriculum committee, then we could. This would be the basic training for everybody. Slide, please. And then this is sort of the intent of it: compile and give access to up-to-date framework. And a lot of resources in there, so you're not reinventing it. And my final slide is I took from the next slide, please. I took from the disaster psychiatry people at MedStar Washington Hospital Center, and it's a way too busy slide, but it reminds us of how much is going on. And this is just a medical system, much less everybody else. Okay, I will go ahead and if we can kill the slides. And again, any more questions or discussions? One thing I wanted to say is I was surprised at how little distress after the first couple days the airline crash elicited, how little. I was expecting more media calls, more calls for services. I think it was because it was a discrete incident with mainly people who weren't from the DC area, and it didn't impact our fuel, cooking, fire, heat. It was impacts people who felt grief about it, but the physical needs were not affected. And again, I'd be interested as to other people's thoughts.
I'm curious, has there been any impact on use of Reagan as an airport? Did it drop passenger loading of planes, things like that? So more longer term, or maybe short term, but
they closed down a couple of the runways and they're decreasing flights. And I think all of us were afraid that somebody would blame it on DIE efforts, and there was some attempt to do that.
Yes.
Other people's thoughts?
Pam, I was wondering, another sort of slow burning disaster we have going on here in DC is the federal workforce. I know it's not a concrete, immediate disaster, but do you see any correlations between a longer term, the layoffs and the distress, especially in this area for all of the federal workers and disaster planning per se?
That's a good question. I think we all are apprehensive, and there is fear and anxiety about that. I hadn't yet labeled it as a disaster, but in retrospect, we may well. I know that our clinic is seeing a number of people who are concerned, including requests to be able to work from home and saying they have a mental disability. And we've been talking about whether that's appropriate to write a letter saying they can work from home. You've been around this area for a long time. I'm assuming you have some thoughts about that, the disaster aspect of firing your federal workforce.
Well, it concerns me because we have, I mean, I'm sure all of us have a number of patients who work for the federal government. So it's not just our patients, but it's also then their family members, their extended family members. And you talked about the long-term effects, you know, post a disaster. And I see our extended community slipping into the long-term effects without a quote unquote identifiable disaster.
Well, don't worry. There will be more identifiable disasters if we're laying off federal workers, air traffic controllers. You know, that was one of the questions, whether or not they were short-staffed at Reagan and with only one air traffic controller. I'm saying don't worry facetiously, you realize, but
I know you are, right. Plus, if we don't have vaccines and things like that, we will have a countrywide disaster, but.
And then if we have civil war.
Yeah.
I had hoped to get Dr. Xenakis to say something. Steve, are you still on the line?
I am. I mean, I'm listening to you, and I think it was an excellent presentation, and I'm glad to see that we've got so many people that are interested in this topic. And I think that the question that just is represented is that our country, our communities go through periods that are very destabilizing, and they can be destabilizing for groups and individuals. It plays out differently. But I think that one, you made a very good point about we as a profession being prepared, thinking about it, knowing as much as we can know, and bringing together all our experience and knowledge so that it can be applied as these various scenarios play out. And that we have a professional and perhaps an ethical responsibility to in fact, do that preparation now. And it goes back to the adage, you know, back to General Eisenhower, you know, that, plans end up all going awry once the action starts, but planning is indispensable. And I think that what you're talking about is very important for us as professionals in this community to organize ourselves and do that kind of planning and training, and to make sure that as many of our colleagues are trained as possible. And so that when something does occur, that we can work and support these people effectively. So I encourage us, and I think there should be follow-up in your committee of one. I hope you get other folks to join up and get the curriculum out that USIS has in fact put together, which is excellent.
Okay, Anne, I suspect we have time for one or two more comments. We see a Dr. Mack from Howard.
Yes, I'm Dr. Mack from Howard. I'm a PGY2 resident. I'm a Louisiana native, and I'm a Hurricane Katrina evacuee. So I was wondering, what type of disaster training or exposure are you giving your residents at Washington Hospital Center? And are you able to mobilize them in instances of disasters?
Good question. So Washington Hospital Center has residents and med students from Georgetown. They aren't our psychiatry residents. What we've been doing so far is grand rounds and other training. As to whether or not they would be able to be utilized in a disaster. I would say in an ideal world, yes. We haven't, well, I was going to say we haven't gotten there. We have gotten there as far as COVID, because certainly they've been part of the response to COVID. But more is always good. What about at Howard? Is there exposure to this topic?
No, we've had one PGY4 resident that's done one rotation. No, well, she's done one grand round. She's from one of the Caribbean islands, and she was doing grand rounds on climate change and Atlantic hurricanes. And I've been working with some mentors at LSU New Orleans, looking at the disasters of Atlantic hurricanes and cyclones in Southeast Asia, but not much exposure as a resident. And we don't really hear much on how we can actually get involved, even on the national level, or to be connected with FEMA or anything like that.
Yes, there is a APA psychiatric dimensions of disaster, and that would be worth you attending. I think Kurt West is in charge of it at the moment, who's a retired Navy psychiatrist. The military has often been leaning forward in this area because we have so many natural and man-made disasters. But maybe what we should do is anybody who's interested, email me, and we can start our disaster psychiatry committee and try to help educate. One of the challenges for disasters is they don't come in an easily predictable way so that you can build it in the curriculum, but you can build learning about them in the curriculum.
Yes, I mean, disaster is actually a public health issue. Is a kind of different organization in the community, outside community, service organization, doctors organization, so all become involved in a disaster situation. One thing I was thinking about the training, one low-hanging fruit could be learning about psychological first aid. I think for a psychiatrist, it sounds very easy, but it still is very effective. I saw it myself when we tried it in the Newtown shooting, and it was very helpful. And it's very easy to learn, but the practice is more important. So more you practice, you learn about it, and it's a very effective tool, psychological first aid.
One of the things that struck me through the DMAT system was the level of organization within the program. And any first responder organization practices and goes through drills, and to expect just local psychiatrists to step in without some underlying organization, or at least some way to insert them in there in a disaster, is just, I think it's a non-starter. It would be a lot of confusion.
Right.
At least that'd be my concern.
Yeah.
And of course, most of the time, this work is not paid, and we all have the competing interests of wanting to make a living, take care of our families, spend time with our family, and do what we perceive as the right thing. I got an email from Dr. Mack about my email. Could Kathy or somebody just put my email in the chat? It's Elspeth Cameron Ritchie at gmail.com, but nobody can spell Elspeth, so it's easier to have it written down.
It's your whole name, Cam?
Yep.
Elspeth Cameron Ritchie
At gmail.com.
at gmail.com.
Yeah, I think you probably have it somewhere.
I'm sure I do. Can you check in chat and just make sure I did it correctly?
That's good.
Okay. I know that we've run out of time and we could all keep going. I want to let everybody know that our CME guru, Ms. Kathy Thompson, plans to send out our CME information tomorrow. I think I see that she's on, that she managed to get back on, but she did lose her power earlier. Part of our man-made and natural disasters. I'd also like to encourage everybody to attend our March CME event, which is AI and psychiatry, and our April CME event, which is going to feature Dr. Chris Flynn, who is on the call with us, and it's aeronautics and psychiatry. So it's a timely follow-up to Dr. Ritchie's disaster and psychiatry.
I hope you're not equating aeronautics with disasters.
No. It is one of the safest forms of transportation, actually.
Well, true.
One other thing I forgot to mention.
1 in 1 million.
Yeah.
So the group for the advancement of psychiatry, I'm a member of the military and veterans subcommittee. They also have a disaster subcommittee. So if you can get yourself invited up there as a guest, then that might be another way to go to that committee meeting, and I can help facilitate to getting you invited. I see we have another hand.
Yeah, Dr. H.
Hi everyone from down under. I'm a military psychologist in Australia. I particularly wanted to ask about any innovative methods besides the fundamental things that we often know about in the physiological de-arousal. And is there anything that is being done in the US that perhaps in the military or in other environments that use a little bit more body-based or, things that I might not know about?
I tell you what, let's let those who, we are past time, let those who want to leave feel that they can leave without being rude. Is that okay, Anne-Marie?
Yes, that's fine with me. And then the rest of us can stay on and chat.
So I'll give an answer to that, and then I think there will be other people who won't want to have input. We tried for a while to focus on reducing physiological arousal with propranolol and others. Who was a psychiatrist who did the work on that in Boston? Not very much came of it. And in the military setting, we didn't want to be reducing physiological arousal too much because we wanted to be able to take the hill and fire back. So I think there's been attempts, but I don't know of anything right now that's going on. Now, Steve Xenakis, I know that you have been working with AI and quantitative EEG. I don't know if that includes any pieces of that.
Well, I mean, there aren't any formal projects, but there have been over time various, pilots looking at, devices like there's alternating current cranial electrical stimulation to help with the sleep and just being able to people to calm themselves after an event has occurred. And that's still playing out. And, people are sort of trying to systematically collect data. And there's been more speculation or conversation about particularly in the combat theater, after multiple engagements, could we think about using some of the psychedelics in that arena? And particularly, some's been written about the use of MDMA. So principally, that's what's going on right now. But there aren't any formal projects that I particularly know about that we might be able to point to that could be useful for you all.
Dr. H, do you have a specific project?
I think you heard you, Cam.
So when you say psychedelic, are you talking about psychedelic itself or psychedelic assisted psychotherapy?
We're looking at the medication with the therapy and how that would work, particularly in the right context, and again, we've got a lot to learn about how we would organize that.
Sure. Thank you.
Sounds like another grand rounds.
Mm-hmm.
Okay, well, it's getting late for me at least. So if we got no more burning questions or conversations, I really appreciate your input. I'd really appreciate your involvement. Just to go back, Washington, D.C. is a city that historically has been hit by all kinds of rampaging soldiers from the Civil War and other events, including January 6th. So the good thing is we've had practice, at least law enforcement has had practice. The other thing I'd like to say is it's thrilled to see people from different district branches and from Australia. I don't know. That's great. So let's keep up the good work.